Good evening, everyone, or afternoon for some. This is Lil Caprella, and I am here this evening with all of you to present my program, Elevating Your Instrumentation Skills, the Dental Hygienist Unplugged. Thank Viva Learning and Premier Dental as sponsor for this evening's program. Let me begin now. Just going over a few objectives. First of all, I think that it is important for me to explain to everyone why I felt this program was beneficial. Whether you're a novice dental hygienist, meaning just out of school last couple of years, or whether you're very experienced, I think all of us know that we reach a point in our career where we continue to do what's comfortable for us. We don't really look back and say, hey, are we using the best technologies that are offered today, or am I more comfortable with what I have used in the past and this is where I want to stay? So my objectives kind of go over a few different things here. I think we should stop and evaluate and compare what we use today in our instrument setup to that we've used in the past. Have we made changes? Then we're going to go through the rationale in selecting different things like color-coded screening probes, looking at hand and power-driven instruments, curette designs, different styles of curettes and why they're important, power and hand instruments, air polishing, implant scalers, a little bit about cordless prophy hand pieces, and then selective polishing. So let me continue here with our slides and just kind of going back a little bit to, I think we all can appreciate so much of what's changed in dental hygiene when we look at where we came from and what we do today. Those early years, provided us with very minimal instruments, and today we are looking at a very different setup. Looking to the left, I learned with, some basic instruments, and I know those hygienists that preceded me had worked with even simpler instruments, sometimes very few. And then when you look to the right and you say, hey, I'm looking at a cassette and there's 2 racks of instruments, maybe not everybody uses that many instruments in a dental prophy, but that's the point of this lecture, is that we do different procedures day to day. Some of those procedures, we can work with 3 or 4 different scaling or curettes. We can sometimes use ultrasonics or air polishing in cases without using very many, instruments. But when you look at some of the advanced cases that we now treat, we have to identify what our setups consist of and how we need to individualize some of these setups for those cases. So I look back, and on the left is my little hygiene picture, and then I look to the right and I see somebody very different, and I see gloves and I see loops and I see a mask and safety glasses, and believe me, that has definitely transitioned us from evolving from a very simple role of instrumentation to something much more advanced, analytical, and diagnostic. So I think it's important for us to think about this. The only thing that gets in the way of new learning is old learning. We don't want to move away from what we're comfortable with, what we've felt secure with. A skilled clinician, I think, prides himself in the fact that they've mastered a skill in the instruments they use, but they don't open the pathway to learn new ones when they feel that maybe they just don't understand how they're used. So there's 6 dangerous words. We've always done it this way. And that's what I hope that you'll move away from, because that's the mentality that gets us into this rut of using the same thing day to day. So here's a little bit of that simpler setup. Years ago, it was the Explorer probe and mirror. And then, of course, the instrumentation consisted of your prophy angle and prophy paste. Of course, it wasn't a disposable prophy angle back then, but we had very simplistic scalers. They were small handled. They were basically sickle or some type of posterior sickle scaler, maybe a curette, depending on the type of patient we worked with. The contemporary setup shows you how far we've come. We're looking here at ultrasonic instrument tips that have now changed from just a very broad tip to slim tips and right and left angled tips. And then we now have tips that have a peak coating on it for implant safety. The cassette shows you how an ultrasonic insert should be part of the setup. It should not be an adjunctive instrument you pull out of a drawer in a bag. It should be part of every patient's setup and kit. Air polishing has become very influential now in the marketplace because of the changes in how that operates, what you use with it, and I'll touch on that again in a little bit. This little schematic that I created kind of shows you the categorization of our instruments. You know, you look to the left, you have your diagnostics, and then under diagnostic, you know, we use our explorers, we use our probes, and then the explorers, we're checking coronal surface areas, we look at pits and fissures, and then we also have to evaluate root surfaces. So our explorer has to do more than just detecting incipient lesions and maybe just running, you know, the tip along the gingival margin. The probes, of course, are even defined further from a screening probe to a more standard probe to a furcation style probe. So we have a variety to select from there. In the hand scaling area, we have gone through the universals that start with scalers. You have curettes that are universally applied with 2 cutting edges. You have the langers, which are a combination of a Gracie shank with a universal style toe. We have files. We have implant instruments now have also diversified to the point where we have resin style implants, we have titanium style implants, and we're even using the air polishing with glycine to address implant debridement. The site specific areas, we use the curettes, and there are varieties of different curettes too that enable us to use those curettes in more advanced cases, in deeper pocket depths, and when we depend more on a rugged type of shank design. And then our power scaling, as you can see, we have our ultrasonics, which then divides into magnetostrictive and piezoelectric. And then some of these, of course, you know, bring us into all these different styles of tips. And then our air polishing. So now we see how we've started with a very rudimentary air polishing that used bicarbonate, and it was more abrasive system. Many people steered away from it because they didn't like, you know, the effect of spraying the patient and the cleanup and even the high sodium content of the powder. And now we have other varieties of powders that are offered with the air polishing. So when I look at this schematic and then I go to the next one, what I see in my next, my next slide here shows you how I tried to list a little bit of some of the names of instruments or types of instruments that most of the general hygienists today have been used to using. And this is where they stop. And sometimes they don't attempt to even look at screening probes or a different style of explorer or even more variety of Gracies when they feel the need to use them. So I just wanted to show a little bit of comparison there of how, you know, I minimize that a little bit to just point at the areas that we have used. Probably the majority of our setups consist of these. And that, you know, just brings us then to the first step in looking at the whole ergonomic issue in instrumentation and how we've evolved from a small handle, very fine handle, to more of an octagon. And then, of course, we enlarged the diameters of instrument handles, but didn't really get into some of the resins or the silicones or any of those textured instruments until much later. Now I think so many hygienists are pointing toward using some of these lighter weight, larger diameter, and the contours have changed. But I think the grip is so important because using these instruments with wet gloves and the way we work throughout the day, I think it's important for our grasp to be very controlled and comfortable. And this just kind of breaks down what is recommended. When you look at some of the fundamental textbooks on periodontal instrumentation, and this one in particular, Garrett textbook was used often in the school settings where I taught prior to my current position. And what we recommended, of course, through this text was moving toward the large diameter, looking at diameters that are anywhere from 5/16 to a 1/2 inch in diameter, light weights, hollow handles, as opposed to solid metal handles. The surfaces, if they were stainless, if they were gnarled, that helped to give you that slip-resistant texture. But then as other instruments started to move toward the resins and the silicone textures, they found that that was even more comfortable because it gave you a little better passive feedback when you put grasp pressure on the handle. You just want to eliminate some of the small diameters, the heavier instruments, and the smooth and slippery ones. So you can see here where you get much better control. And as you do go larger on the diameter, you'll find that the whole grasp of your hand will open up a little bit more and relax. And that's really ideally what a hygienist looks to achieve when they're working all day repetitively and one patient after another. The majority of the time we spend is with these instruments in our hands. One of the recent additions, I, of course, am employed with Premier Dental, so I have been involved with some of the input in the research department when we've created things that hygienists really ask for. And these are the Premier Air instruments, and the diagnostics and the scalers and curettes are designed in a very balanced, comfortable approach. Ergonomically, it improves everything about what you do in scaling root planing procedures. They're very rugged, and the polymer stands up well to sterilization. It also has the Smart Sharp technology, which gives you the high quality stainless steel, but with a very precise edge that maintains its edge well. Notice the gram weight though on these, because some of the instruments that most hygienists are using could be somewhere around 16, 18 grams, sometimes as much as 21 grams in weight. So this really lightens up the grasp and the balance in the hand. You can see this in the probing, using an Explorer or a probe. The diagnostics are in the aqua color, so it gives you a nice light grasp. And when you are doing diagnostic procedures, you're using a pen grasp, so you're not expected to use such a very firm modified pen grasp, but a very light, and that handle kind of lends itself well to that light grasp. Your standard probes, of course, you don't eliminate those. They're important. They become a very important part of every setup that we put out for our patients, no matter what procedure we're doing. So you see some of the standard probes. Many of us choose those consistent with what we were schooled in, depending on where the measurements and the color codings are. The important thing about probing is to make sure that you use a 2-point contact parallel to the long axis of the tooth, and that you do 6 readings per tooth. That's when you do a comprehensive periodontal exam. So, screening a patient is one thing, but once a patient has been determined to need a comprehensive periodontal exam, we should recognize we need time scheduled properly so that you can chart all of the readings that you note as 6 readings per tooth. As we look now at the new periodontal classifications that have emerged from the 2017 proceedings, this was an international meeting that consisted of many countries coming together to present a more unified approach to how we diagnose periodontal disease. And recently, some of this information has been shared, through CE programs, coursework, either in journals, articles, webinars. And you can see here that it kind of breaks down for you that this is not just a group of people who said, hey, let's do this differently because it's easier. The PSR screening and recording system that came out of the 1991 proceedings made it easier for the general practice to green people, that's different. Now at this point in time, the 2017 classification that has now been published, and it will take a little time for the general practitioners and periodontal practices that are used to doing their classification in the old system, that they're going to have to rework some of their charts and information. I will not get into this in detail because that's for a whole separate course in itself. What I just wanted to enlighten you on is that it is kind of following more of a medical model of, diagnostic staging, so that when you have a medical disease, we use stage 1 through 4 to denote the complexity and the degree of disease state that a person is in. So this new framework is now aligning up a staging so that we can now determine patients are staged in a 1 through 4 when they are diagnosed as having periodontitis. But in reality, what you start with is a screening process. And that's what I wanted to bring up as far as using a screening probe is important in practice. We shouldn't put that aside for, only special cases. This can be done on every new patient that comes in, or even during your maintenance patients, where you take a screening probe and just the color coding itself helps to denote 3 broad categories: health, gingivitis, or the potential for periodontitis. So if you use this and you know that a patient is, their gingival margin is at a normal level and you're in the green zone and there's no bleeding, you can determine this patient is a healthy patient. When you do see that there's some bleeding, you know that gingivitis is a known fact, that even if the pocket depths are shallow or within reasonable limits, that if bleeding exists, there is inflammatory state, and it's gingivitis. But anything beyond that in the red zone of this color-coded probe would denote the potential for periodontitis. So you would stop the screening, and then that patient would be rescheduled to have a complete periodontal examination done. This makes it a lot more efficient in a practice when you start with this. And if you think about the AAP classification and the way it's changed, now what you're going to determine is if the person is either in the healthy gingivitis category or if they're in the periodontitis category, which then you would go through the determination of stages, or if in fact it is something that's related to periodontal disease and systemic etiologies, then that would be your third and extraneous category. That would be, of course, you would approach that differently. You would go through much more medical information than to determine what is the etiology. So the screening probe will help you. It'll help you to determine better visibility in the presence of bleeding and exudate. It provides just a more efficient approach to initial screening. It's very safe on the root surfaces, the implant structures. And again, as I said, it's more compatible to approaching your new periodontal classification categories. Furcation probes, I find that when I do live programs, there are quite a lot of people, when I poll who does use furcation probes, there are a lot of people who do not. I think unless they work within a periodontal practice or an implant practice where they see much more advanced cases, they feel the need to have them in their kit. I don't even suggest they have to be in every setup, but I think it is important to have some of these on hand. Some can be color-coded, some could be just plain, depending on how you prefer to read and classify from 1 through 4, your classification of furcation. But you can see with the color coding, it does help you to determine how far that probe goes within a furcation site. But it is an important instrument if you are working with more advanced periodontal cases, so that you can better determine more information beyond the probing depths. And believe me, a straight probe is never going to give you the detailed information that you can get from a furcation probe. This also provides you a little bit more direction as to which which way you're coming into the furcation. If you're checking a buccal furcation, of course, you come right in between the two roots. When you're coming through to assess a distal furcation, you can come in either from the buccal or the lingual. But when you are assessing a mesial furcation on a maxillary molar, you'll see that you have to assess that best from the lingual. Trying to get to that from the buccal is near impossible. So these three photographs kind of show you the directional insertion of a furcation probe and how important that is for you to be able to reach or determine how far that probe goes in to determine the classification. And you can also acquire instruments that have a standard probe on one end or a furcation probe on the other end. This is an ACE probe by PDT, and this is a nice instrument if you feel that you want to have two instruments, that can be combined into one to minimize how many are on your tray. And this would also help to cut down on the number of instruments you have in a kit. The other instrument that I think is important to elaborate on a little bit is the ODU 1112 Explorer. And this is a great instrument for evaluating the root surfaces, and especially in pocket depths that are beyond shallow, but in 5 or greater millimeter pockets. This also can be acquired in what we call an extended shank. The Euphrates instrument, the ODU 1112 AF, means after 5 because we know that the after 5 is indicative of their shank length. So you can see that, if you do purchase something even longer, it will give you even more reach to some of these deeper areas, and the trunk of the tooth that's longer, and some individuals might prohibit you from using a standard 1112. But know that this instrument's an important instrument in scaling and root planing. It's a given. If you are trying to use a CH3 or some other type of explorer that has a much shorter tip, you really won't be able to reach it well. This shows you the adaptation when you compare it to a 17 explorer. You can see here how a very short tipped 17, when folks see an instrument like this, they see a nice long shank, they think, oh, this is great, this will get deep into the pocket. It might, that's true. But you can see that when you have a concavity, and there's even calculus that's far along, even back as far as the distal aspect of that concavity, that short tip is never going to even reach it. In fact, you won't even be able to adapt that tip to the concavity at all. And 1112, as you can see, the way that just kind of wraps around the prominent part of that root and into the concavity, this is a much better instrument for you to be able to do a final assessment after a scaling root planing. What I did was I created a video too so that you would be able to see the directional placement of this instrument. You're using both sides of this tip, so you see that you would use the one aspect against the distal, submerge it, insert it, turn it. After you come out of the distal, you turn it so that the tip is pointing toward the anterior section of the mouth, and you do your short overlapping strokes to go across the buccal. Then you reinsert the distal, come around again to finish the buccal, finish the mesial, just kind of readjust that tip against, go right along again. But I think it's good to see this in action, so that, and you can see how deep that actually can go, because it's created much like a 1112 Gracie curette. Now, if you're looking at these two pictures, I mean, just take notice to what you're addressing here as far as which instruments am I going to choose to treat this patient. Well, you look at the gingival height, you see that there's a considerable amount of recession. You see root exposure. You see stain along these roots, but you also see calculus in some of these areas. And if the calculus was only in the supra area, it wouldn't be so complicated. But if you're going subgingivally and you've got teeth that are out of position, or you have, irregular heights of the gingiva, and then you've got to get all the way to the back of the distal of this tooth. This is pretty complex, and it's not enough to just pick up a universal curette or pick up an ultrasonic tip and just kind of zip up in there. Patient might be very sensitive. The stain would be hard to remove, so you're probably going to have to consider or think over a combination of different instruments when you're faced with these kind of cases. So it is critical to take a moment and you evaluate, what is your tissue tone? Is it tight? Is it going to be hard for you to use a large bladed instrument? What is the inflammatory state of the gingiva when you're about to do this scaling? Is it, excessively, inflamed? Is it fibrotic? Is it edematous? Are you getting a lot of bleeding that will prohibit your ability to really feel, see, work these instruments where they have to fit? The osseous topography also affects which instruments you may choose. And where certain areas have clinical attachment loss, you're going to go maybe deeper with extended shanks, smaller toes. Even the root morphology. No two teeth are alike. I mean, any different person you treat is going to have different morphology in their root structures. Some people will have deeper furcations, longer concavities. It's going to be different in so many people. The access to these teeth can also depend on a patient's ability to open wider, their time of, chair time, how much chair time they can do if you're going to do extensive scaling and root planing. And then, of course, the obvious is the type and amount of deposits. If you're dealing with mostly biofilm that's subgingival but not that much calculus, you may switch over to more ultrasonics, but using a finer tip to be able to reach and assure that you're removing a lot of the biofilm effectively. Full mouth periodontal debridement is a procedure that was defined probably about halfway through my career as a hygienist. And it was a very necessary term because it is conducted to remove any heavy, soft, and hard deposits that enable the dental professional to perform a more comprehensive evaluation and diagnosis. So you look at this picture and the before and after shows you what happens after you remove all the calculus that you see here. And if I had to probe the case, on the left, I know that it would be extremely difficult to even insert a probe in any of these areas. The calculus makes such a bridge, it connects these teeth. And once you remove it, you can see that you're given much more access for your explorers and your probes. There is a specific insurance billing code for periodontal debridement, which is 4355. And that's used, only if you are doing a full mouth debridement prior to your examination. You don't use this code or this procedure again later, unless this patient goes many years before, they're in the same situation again. The preferred instruments for debridement are usually your ultrasonic scalers. You can start with more of a broader, heavier, supragingival tip, and then transition more to your thinner tips. The water lavage in the ultrasonics really helps to assist in the results. It does help the flush, as well as cooling the tip. If you're using magnetostrictive inserts, you would be using that water to cool the tip, especially if it's running for a while. Pardon me. And then go through with a generalized scaling with universal scalers and curettes. But this is not a time that use the finishing curettes. This is where, people get confused, I think, because in school we learned the Gracies to be part of a setup and felt that that was always inclusive to every procedure we did, every prophy procedure, every scaling procedure, but not always. In this particular procedure, I think at the debridement, you want to do exactly that. You want to be able to remove the heavier calculus. You want to remove and move a lot out of the way so that your probe and explorer can take over from there. Most clinicians underutilize the maximum benefits of ultrasonics because most of the time they're using ineffective inserts and inappropriate inserts. So that you have to stop and look at what you have, determine what you need. And the other 3 points are obvious, that if you aren't very sure about how you adapt the tip or activate it, or your strokes are just ineffective, then I think it's mindful to look at a live program, a hands-on workshop, where people who are very knowledgeable and skillful in ultrasonics can really show you how tips are adapted. But when folks are not even choosing the right inserts and they don't understand the difference between some of the heavier tips versus the slim tips and the right and left type tips, then they're really not utilizing these inserts the best they can. So when you are doing your initial deposit removal, just to detect, you're going to remove the moderate to heavy calculus. You use those standard inserts. They're your triple bends or the straight universal designs, and they're utilized, in a little bit higher power, not high power, but a little higher power than you would use typically for perio cases. And then if you're using your thinner, slimmer inserts, this is when you get to the stage of more finer deposit removal, and you're just doing more biofilm disruption. So at that point now you're finishing a little bit. And this is when you try to use more of a channel stroke to finish. And this particular article was very good in explaining that in Dimensions of Dental Hygiene, where the channeling is described as you move your instrument tip more horizontally. You're going to the apical area and you work back and forth to pretty much fragment some of this calculus, but moving this way and coming coronally as you keep working that direction is a better way to kind of break up the calculus. And now you're kind of preparing yourself to use your mini bladed instruments, your more area specific curettes. And it's a better sequencing for the best outcomes. So your thin and your extra thin inserts are really best for your biofilm disruption and for the completion. But you don't start with these. That's how people break these tips, because they try to accomplish the heavier tenacious calculus using a slim insert, which is not designed to do that. So this is the channeling is really a good approach in removing those deposits. Another thing that's researched, because there was a number of years that files kind of disappeared off of trays, and it was because I think when we began using ultrasonics more and more for subgingival scaling, folks kind of got away from any kind of files or heavier hand instruments, and they resorted more to the ultrasonics. But periodontal files are a great asset to have a few of these handy, because they do help to fragment heavy burnished calculus. And I like the idea that they work, if you work the same way as that channeling direction, you do more of a horizontal back and forth stroke. These little blades in the file are designed to be used that way. This O'Hare debridement file is a tinier round file that's great for these narrow deep pockets. But if you're using a standard Hirschfeld type file and you want to go across a distal or some root surface that is either exposed or not exposed, but there's burnished calculus, this would be a great tip to use back and forth. And I think that it also helps to preserve the CEJ. You don't want to gouge. And I think we do this because of more of the vertical, apical to coronal directional strokes that we often do in a very repetitive fashion. And then we get a little heavy-handed. And sometimes we find that we actually do create some of that problem for the patient. Now, looking at something like these two pictures show me totally different instrumentation. We see this is more shallow pocketing from the way the gingiva appears. Of course, I don't know that unless I probe, but because of the malpositioning of these teeth, you can see that plaque control is greatly compromised, probably very difficult for this person to keep, on top of the interproximal cleaning. But you see that the gingiva is inflamed slightly, and it's all related to the associated plaque and calculus. Then you look at a patient like this, who obviously has had clinical attachment loss, but no real gingival inflammation. And I just know, because I recognize the case from some of the programs that I do on high-risk adults, that this is a patient with Sjögren's syndrome. And their mouth is very dry, as, of course, the side effect of that. And, and medications sometimes create this hyposalivation or xerostomia. So when you have roots like this that are exposed and they almost look kind of hardened and glass-like, probably very little deposit subgingivally, but you don't want to ignore the fact that this person may need some subgingival scaling, and that tissue is going to be a lot more difficult to and to adapt instruments that would be broad bladed, large, longer toe, so you do have to be extremely careful in the instruments that you choose. The other challenge is trying to reduce some of that burnished tenacious calculus. I would have cases like this that would come in that you look at the gingiva and, it doesn't look all that bad, but that, once you start to probe, you get a better idea. Well, when you look at a radiograph and you can obviously see that there's obvious clinical attachment loss, but I want you to kind of look closely at some of the calculus that is on the roots of these teeth and how they appear to almost look burnished. It could still be some pieces of calculus that won't be difficult to remove, but for the most part, a case like this might be one of those 3 to 4 month maintenance patients that come in, and no matter what you do or how deliberate you are in root planing effectively, you might still find that you'll have areas like this that end up being burnished calculus. They just will never get smooth enough. And we have to determine what can we use for these cases. So, we see today there are instruments that are designed to be pretty much sharp and free. They are heat treated so that, the sharpness lasts a lot longer. We look at tips and the placement of tips and how we want to make sure we're using the active sides of tips. So we've got our ultrasonics, our piezoelectrics, we have our curettes. But more importantly, we look at the toes that we select. We look at the length of the shank to ensure that these instruments are all going to be designed to reach areas that, that do give us this challenge. One of the things that I've always moved to, and I remember this from a course I took when Anna Pattison, who is well known for her instrumentation courses, programs, and publications, that we don't have to use the instruments that we were taught had to be used in a site-specific area. Our Gracie 1314s were designed for distals on our posterior surfaces. And yes, I still would use that instrument, and that's what you see here. But further down the road, when I had patients that came in with very tenacious or burnished calculus on a root of a deep pocket and on a distal surface, I found at times that a Gracie 5.6, especially a longer pocket scaler, what Premier calls the extended shank instrument, that gave me a longer shank to get deeper into a pocket. And then I would use a standard toe if I felt there was a broad area to reach. If it was a really tight, small area, I would go more to a mini toe. But this was stronger. This gave me a stronger, less flexible shank. Gracies are flexible. They're not designed to be used for very tenacious calculus. They're finishing instruments. That's why they are called that. But when I use a 5.6 versus a 13.14, I get much less spring because that shank is so straight and it's strong. And if I fulcrum properly so that I'm getting as close as possible to the site, I find that that becomes a very powerful instrument in getting to the, to get to the outcomes I expect. This is your line of Gracies. Anybody who has used Gracies or were taught on Gracies know there's a whole series of them that started out going from 1, 2, and went all the way up to 13, 14. And the 2 that you see at the end here were added much later in my career. And I just want to show you what has changed. So the 15, 16 came out as kind of a substitute for the 11, 12. So when you use your 11, 12 properly, it's designed to be used on the buccals, the mesials, the linguals or palatal, and the mesials, but not the distals. Then you always use these 2 instruments in a pair. The 13, 14 was always used on the distal. So when the 15, 16 came along, it replaced the 11, 12. When the 17, 18 was created, it was created so that that blade is designed with this shank to be used the same way that you place your 13, 14 on the distals. So this is the way, people could replace the former, but some people choose that and you know, maybe stay with this and they use this, or the other way around. You know, they may like the 15-16 better because it's not as straight, and they select this, but they still use this for the distals. The other thing is that there are many instruments that you can also purchase where you get different colors that could be color coded for identification of the instrument or identification of a certain kit. If you used all one color for a scaling root planing kit versus a dental prophy kit or perio maintenance kit, or some people will just like to have maybe a particular color to denote that hygienist in the practice and the kits that are used for their, you know, the ones that they had selected themselves. So this shows you the difference. Look at the variation as far as the Gracie 17-18. Boy, that really made a severe angulation change from the original Gracie 13-14. And this is the extended shank of the Gracie 13-14. So you can see that if I was trying to use this instrument in a 7mm pocket, I'd have a lot more trouble. If I went to something with a longer shank, I can certainly reach that area much better, because now this will submerge even further before I have to adapt that working end. Let me show you here the comparison of the Gracie 11-12, the 15-16. You can see the improvement as far as the placement. Okay, they both get placed easily, but I found that with the 15-16, as I work around the buccal of the tooth and I'm finishing the stroke on the mesial, that when I use the 15-16, I can just roll that instrument a lot easier. It kind of just fits and wraps itself around that tooth a little bit quicker, so that I don't feel that I have to do as much maneuvering with my grasp. So I think that, you know, this has been a great improvement over the 11-12. In the 13-14, if you were working in the posterior in someone's mouth and they had a shallow pocket, probably no trouble. But when you get to something that just goes a little deeper than 5mm, and you're coming in with that instrument and you're adapting this blade on the distal of a deep pocket, now you have to get that blade further apically. Naturally, your hand has to be uprighted for you to be able to get that instrument to reach. Well, with this angulation, you can still maintain a very stable fulcrum toward the anterior part of the mouth. And you can see here where that allows that adaptation to be much easier and smoother for the clinician and easier on the patient too. So it keeps your wrist in a more neutral position. Then you have other nice features too, where insight markings are, you know, Premier had added this marking to their longer shank instruments. And the reason is that, you know, if you probe a pocket and you get 6, 7, 8mm pocket, but you don't realize that there may be a ledge of calculus somewhere that's going to stop your instrument from really reaching the base of that pocket and effectively removing all of the calculus, that marking will correspond with measurement. So that if you're up in this area, you'd be at about 5mm in, and this would be 10. So if I measured this pocket to be 7mm, and then I insert this instrument, and somehow as I get in there, I find the gingiva comes right to that area that denotes 7mm, I know that I'm at the base of the pocket and I'm not concerned. The mini toe is great because it makes a shorter toe, so that as you get a little further down and the root surface gets more narrow, you know that this little toe here, as short as it is really going to work better. It's going to fit better, whereas a standard toe would be longer, and you'd only get so far and then you'd have to stop. You know, you'd never be able to reach that area. The rigid Gracies are thicker in this area here. So you can feel when you use a rigid Gracie and you try to remove something a little more tenacious, even though they're not supposed to be used for tenacious calculus, but in some situations you might find that this could give you just a little more strength, rigidity in, you know, smoothing out the roots and keeping a little more control on the instrument. This just gives you an idea of how, when you buy a brand new instrument and the blade is a universal blade and it's wide, it can only go so far. And sometimes folks are trying to work within a furcation area, or even the tooth and the root proximity might be very tight between two adjacent teeth. That some of these curettes, they just get wider and wider as you go further up the blade. And you can see how tooth and root morphology really is the determinant of why people are starting to look at changing the way these blades are designed. To show you an example, these are some of the universals that you might see, on anyone's setup, and they're great. But many people kind of, only go so far with these, then they feel that they can't really work very effectively interproximally, because the universal blades tend to be round toe and a little bit wide in the working part of the tip. This is what many manufacturers are starting to do. They're starting to narrow down some of the blades without compromising the integrity or strength of the blade itself. So this is just an example of like a McCall's 1718 and a McCall's 17S 18S. I'm sorry, it's backwards. This is the S, of course. But that slimline tip is where it is worked to a more sharper point. And this could work better between the teeth when you get into a tight proximal locations. Here's the PDT, has the Montana jack. This was a very popular instrument when it was launched because it's got a universal styling to it that a lot of hygienists like, because it can be used anywhere in the mouth. And it also gives you that slender kind of insertion tip that I just spoke of, that allows you to get into distals very well in the posterior, interproximals. The Nevi 4 Euphrates Premier Dental, I think there are several other companies too. I don't know if they've named it the same, but these are pretty much same instrument styling. And it's just, just a variety of different manufacturers, so that that, these exist for you to be able to purchase things that will help you to get into these tight areas, get down a little bit further subgingivally, where normally you feel a little fearful to do with supragingival scalars. But these instruments are pretty rugged, but they're also slender enough for you to reach subgingivally. Many people love the 204 series. These give you just pointing out for you the variations of different 204 styles. The simpler 204 by itself is usually a larger, and just a little bit larger type blade, but this is a 204S. And then this, depending on whose company you speak of, sometimes this initial may vary from S204S or an H204S, but then this part of the instrument starts to slender out a little bit more. I used to really use this instrument quite a lot interproximally, and I loved it subgingivally because it reached the deeper cull area, where most often I think we miss those little pieces of calculus in there. And then the H204SD is nice for also distal surfaces, but it also has a little bit longer shank, and it allows you to work this instrument sometimes a little bit deeper into some of the pocketing that maybe these instruments would not be able to adapt as well to. So that just shows you, in using the 204S, you don't have to use it only on the supragingival. Again, if you're a skilled clinician, whether you use a scalar super or sub, it really just is dependent upon how well you maneuver that instrument, because you're skilled at it. If you know not to turn the blade open so that it does any damage or discomfort to the patient, then it can be used in all surfaces. Another instrument that I always like to point out is the Nevi 1, because when I show this to some hygienists that have never seen it, never heard of it, they're amazed at what it is, but they didn't realize what it was used for. The Nevi 1 has a sickle, nice sharp pointed scalar tip on one end, and on the opposite end you have a spoon shape, and the spoon almost looks a little bit like an excavator. But what it's useful for is, once you've used the sickle for the obvious reasons of supracalculus interproximally, The spoon is really nice when you're doing very direct removal of calculus at the gingival margin, especially on lower anterior teeth, because those areas are sensitive. And when you try to apply a sickle scaler, it's not only uncomfortable, it's also difficult for the clinician to get that to adapt exactly right. But this is nice. This kind of fits just into that area. It's also nice for cingulum areas where you might get a little bit of stain in surfaces, you know, where these different fissures tend to trap some stain. But it's kinder to the tooth structure. And then the Langer curettes are a combination of a Gracie style shank, but it gives you two cutting edges on both sides of this toe so that you can turn that instrument when you're applying it to areas like furcation sites. This, for example, of course, it's not a real patient, obviously, but this gives you the visibility so that you can see how it's been adapted. One edge is working on one side of that root in the furcation, and then all you have to do is just turn your hand slightly and use the other edge against the distal aspect of this mesial root. And this really makes it easier for the clinician to not have to switch instruments constantly through the procedure. So Langers can be really effective. You don't have to have them in every kit, but it's a good idea to try some of these instruments if you work in practices where you see patients of this caliber. And I think it's wise to have a few of them sterile in a bag and just have them be there for when you need them. Extraoral fulcrums, I don't know how we didn't use these many, many years ago, but they are so important because you get your hand further away from, you know, the intraoral aspect. It allows you to back up on your instrument so that you can adapt your instruments better to deep pockets, to insertion of the instrument. So you can see that this is really, I think that all students are even taught this now, where we weren't even permitted to do it when I was in school. But you can see that it really provides you much better access to posterior sites. And you know, it's just more comfortable for the clinician ergonomically to be able to back your hand off that instrument but still have good control. My favorite is the build-up fulcrum. It's just, you know, if you have someone with missing posterior teeth, you almost need to have something that you can use your opposite hand, your finger, you can place at the edentulous area, and you just kind of fulcrum right on your own finger so that you can create stability and keep your shank parallel to the long axis. I'm not going to go through all, but it just shows you how different procedures call for different instruments, but also different codes. And when you do periodontal scaling and relating, depending on whether you do several teeth or a whole quadrant, you have codes that are applicable to that. You have perio maintenance codes, and then you have your gingivitis code, which is only done when there is no bone loss, but just gingival inflammation. And if a person does move into a stage of periodontitis, you'll never use that code again. And then this is a healthy adult or child prophylaxis. In implant maintenance, I'm watching my time, we're at 10 of, and I just want to quickly go through this just to mention that there's a lot of controversy with implants, whether you should probe or not, whether you should use plastic or titanium or, you know, stainless probes versus plastic probes. I know one thing, it is important once an implant has healed fully and it has been given adequate time for all of the osseous integration to occur, that when a patient has a baseline, that's what you're using for future appointments so that you can reassess whether there have been changes. Your radiographs, of course, give you a lot of important information to ensure that you see that integration in the core of that implant. Plastic probes have been used, they're safe. You know, you just have to be mindful of, you know, the area should be healed well. You should be in contact with the person who has placed the implant so that you know who is and isn't doing the maintenance. but I think it is important to do. Peri-implant mucositis is when it only affects soft tissues and not the supporting bone loss. So when you have a peri-implant mucositis case, you want to make sure that you can reverse the inflammatory state that you see here, and that would require some instrumentation. And then you have the patient come back to see that, you know, the bleeding has resolved and no longer exists. When you have bone loss, as you can see in these radiographs, that there is definitely radiolucency around these implants. This would not be a case that I would want to instrument. This would be referred back to the surgeon, and they would possibly have to take a look at this to see if other procedures would need to be, you know, in order for the patient's situation to be either arrested or retreated. So in debridement with implants, we have choices. People use hand scalers of some type. They use ultrasonic scalers with the appropriate covers or tips. Some folks now are moving into using more of the air polishing now that we have products that are safe for the implants, even just rubber cup polishing, and some folks have even used lasers to be able to treat these areas. So I think the one thing I want to make sure that I stress is that after the implant is healed and the bone has integrated, if there are threading, you know, areas on the implant that are exposed, in other words, as you go subgingivally, and this is, of course, above the crest of the bone, if any of these threads are exposed, it's a good idea maybe to eliminate the use of a polymer or resin type, a plastic type of scaler, simply because if that should scratch or, you know, maybe peel that, I think that that could be a little bit harmful as far as creating a little bit of an inflammatory reaction. But if that's not the case, they could be safe to use, as well as titanium coated instruments. These are the graphite reinforced resin. They are safe. I know that I have used these two in practice for well over 20 years, never had issues with inflammatory reactions to these, and I know that they were effective enough. Calculus doesn't stick to implants like it sticks and attaches to cementum or dentin. So I never felt the need to use anything harder, such as a stainless or titanium coating. And I felt these instruments were really a matter of choice that we had at the time and felt comfortable with. If you're using ultrasonics, you can see that there are different types of tips that are designed to be safe. The peak, you know, tip is autoclavable. It's not removable, which is nice. And all of this, you know, kind of works nicely when you have areas that are very difficult to access with a hand type of instrument. And these are just some other examples of some of the implant instruments: the Implant by Nordent, the American Eagle medical grade titanium, Eagle Light resin handles, and then you have the Wingrove titanium implant instruments by PDT. And these are all very nice instruments. Believe me, I think that, you know, your choices can be made based on the evidence that you read and what you feel comfortable with. Cement has to be removed when crowns are cemented. You've got to get that excess cement off, because about 85% of the time when there are inflammatory areas around implants, they're often caused by residue of cement that was not removed at the time a crown is cemented. So it's very important to get to these areas and effectively remove the, not only calculus if there is any, but there's biofilm that often sticks around some of the prostheses, but I think that it's important to get any excess cement. So you can see these are all designed in certain ways that you can adapt them better to the situation where you are removing them. And then, of course, loops, I'm just going to zip through this real quick, but just to say that I think a lot of the younger grads that are coming out of school now are all very accustomed to wearing loops because they've been introduced to them early on. Those of you that have been working for, you know, 10, 15, 20 years, maybe you haven't reached the point where you think you need them, but don't wait until you feel that it requires you to be the over 40, I need reading glasses approach. They certainly improve the dynamics of your back, your neck, your arm positions, everything. You don't want to bend. You can see that without magnification, as soon as you start to improve the magnification strength, you can see how well, reading of probes becomes. And then that just goes along with the working distance. You immediately start lifting your head. The optimal distance is 14 to 16 inches. And so if you find yourself bending further and working in such a way that looks like that, you're not going to work long. You have to prevent the bending of your neck beyond the 30-degree mark. If you're going to work like this for a long time, you're bound to have problems with your posture, your neck. Even your arms will be affected eventually as a result of your posture. So that angle of declination should never really exceed 20 degrees. But I say, beyond 30 is even more harmful. And when you do use loops, the greater your strength, the shorter your depth of field. So when you get things that are really sharp in the front, you're going to lose a lot of your acuity in the back. So you want to make sure when you purchase loops that the magnification is strong, but also that you maintain your depth of field so that when you look in someone's mouth, everything is in focus. And the goal of this, you want to go to reputable manufacturers and make sure that you're working closely. If you wear eyewear with prescription, that you work with people, with the eye doctors that you see. And then this is your, I know that I'm running out of time, so I'm trying to move real quick here and finish up. This is your air polishing now being used subgingivally. You now have glycine, and that makes it possible for you to go subgingivally. The erythritol is a powder that has a lower micron size, so it's less abrasive. And if you think you shouldn't polish, I recommend that you address patients individually. People like this, you can't let that go and say, oh, I'm just going to do selective polish. And air polishing may remove some of this, but it depends upon what's associated with it too, calculus versus just plaque or stain. So indications for coronal polishing, you can see that obviously a patient is happier when they see that result. And when we look at what we came from and what we had to use before and what's happened with corded, the coiled cords, the straight cords became a better approach to ergonomics because you didn't get that backdraw of your handle. And so getting away from this means that as hygienists get more mobile, you're going to see that things are getting better in terms of weight, no cord. Balance is great. Your grasp is easier on them. Let's face it, hygienists are unplugged. They are moving in directions that are putting them in alternate care settings. Therefore, having the ability to just jump onto a dental unit is not in the purview anymore. So I think that having cordless handpieces are going to be really just a must for almost all hygienists. So I think that, the thing that we want to remember is we want less cord drag, no pedal. If you don't have a rheostat, you don't have to worry about the reach with your legs. You want batteries that are long lasting so they get you through the day and are easy to charge. And ergonomically, you want something that's balanced well and also compliant with the CDC. You have to make sure that you are able to use a barrier over your motor, the sheath is autoclavable, and then your prophy angle is disposable, and this all complies with the FDA as well. And just be a little more selective when it comes to cases like this. And I know that I am running over time. If you want to see some of the products that we talked about tonight or meet with some of us that are at the Under One Roof meeting, it's going to be held at the Gaylord Convention Center in Grapevine, Texas, July 31st, August 2nd, booth 514. And I hope that maybe if you did jump on tonight, you have a chance to come to this meeting. You'll learn even more. So I thank you for jumping on tonight. And I'm sorry we ran a couple minutes over here. I was running into a few issues too with our power. We're going through some very bad storms. So let's see if anyone has any questions. Can you please share what brand of instruments are sharp and free? I'm only aware of EverEdge by Ufridi. I can tell you that the XP technology was the picture I showed as American Eagle, and they're the two I know that I don't like to use sharp and free because I think that you may find that after significant use, you may have to begin sharpening them. I just think that they hold an edge a lot longer before having to sharpen them the first time, Amanda. But try them, yeah. Okay, thank you, Eileen. She's just commenting that it was a good review for an adjunct clinical instructor. Well, that's good, I hope so. And I think you have to stay on to do, thank you, Ellie, former student. I think you have to answer some of the questions in the post-test, and then you'll be able to get your CE certificate. So I thank you for joining us tonight. And for anybody that was in my area, I hope you didn't get flooded because we've had bad weather in suburban Philadelphia. What was the name of the board that met to determine the new perio? Oh, it was not a board. It was actually the European Perio Society. It was the American Academy of Periodontology. We're talking international periodontal societies that came together that actually discussed and reviewed evidence, research, all of that, and the experts came together to put together better standards and classification. So it's just a new staging and grading process, and I recommend that you take any course that comes along that reviews these new standards, because I think you'll find, not standards, I hate to use that word, classifications, because I think it will help you to speak the language better as you begin diagnosing patients in the future for billing purposes as well as for periodontal classification. Thank you.